Yeah, case management for healthy professionals. Severe malaria. Learning objectives. By the end of this unit, the participants will be able to define severe malaria, discuss the host parasite interaction that contributes to the pathogenesis of severe malaria, list the determinants of severe malaria, and identify group at high risk. Make a diagnosis of severe falciparum malaria. Describe the recommended antimalarial chemotherapeutic regimens for severe malaria. Specify the emergency and the supportive measures and follow-up guidance for malaria patients with different types of complications. Definition: severe malaria. Severe falciparum malaria should be diagnosed if there are sexual forms of a Plasmodium falciparum in a blood film from a patient showing any of the clinical or laboratory severity features. Diagnosis of severe falciparum malaria. A correct diagnosis should be based upon a complete case history, a physical examination, and laboratory investigations. Both thick and thin blood films should be examined at health center or hospital level to demonstrate the presence of Plasmodium falciparum as sexual parasites. Clinical features of severe malaria. Sign and symptoms. Impaired consciousness or unarousable coma. Clinical feature: Glasgow Coma Scale less than 11 for adults or Blantyre Coma Scale less than 3 for children. Prostration: The patient is unable to walk or sit up without assistance. Affected children are unable to feed. Multiple convulsions, more than 2 episodes of convulsions in 24 hours. Acidosis. Severe acidosis manifests clinically as respiratory distress, rapid, deep, labored breathing. Pulmonary edema. Radiologically confirmed or oxygen saturation less than 92% on room air with a respiratory rate greater than 30 per minute, often with chest indrawing and crepitations on auscultation. Shock. Compensated shock is defined as capillary refill greater than or equals to 3 S or temperature gradient on leg, mid to proximal limb, but no hypotension. Decompensated shock is defined as a systolic blood pressure less than 70 mmHg in children or less than 80 mmHg in adults with evidence of impaired perfusion. Call fervorous or prolonged capillary refill. Acute kidney injury. It is one of the signs and symptoms of clinical feature of severe malaria. Acute kidney injury. Urine output less than 1, 2, or 11, 12. Urine output less than 12 ml per kg per 24 hours. Jaundice. Clinical features: plasma or serum bilirubin greater than 50 micro mol per liter, or 3 milligram per DL with a parasite account greater than 100,000 per micro L. Significant bleeding is a sign and symptoms. Clinical features, including recurrent or prolonged bleeding from the nose, gums, or veiny puncture sites, hematemesis, or melena. Table 5 Glasgow Coma Scale. Parameter: eye opens, response spontaneously, score 4. To speech, score 3. To pain, score 2. Never, score 1. Best verbal response oriented, score 5. Confused, scored 4. Inappropriate words, score 3. Incomprehensible sound, score 2. None, score 1. Best motor response obeys command, localizes pain, score 5. Obeys command, score is 6. Withdrawal from pain, score 4. Flexion to pain, score 3. Extension to pain, score 2. None, score 1. Total score 3 to 15. Table 6 is the Blantyre's coma scale for children. Parameter: eye movements. Response: directed example, follow mother face, score 1. Not directed, score 0. Best verbal response: appropriate cry, score 2. Moan or inappropriate cry, score 1. None, score 0. Best motor response: localize painful stimulus, rub knuckles on patient's sternum or firm pressure on thumbnail bed with horizontal pencil, score 2. Withdraws lymph from pain, score 1. Non-specific or absent response, score 0. Total score of the children 0 up to 5. Laboratory feature of severe malaria. Sign and symptoms. Hypoglycemia. Clinical feature: blood or plasma glucose less than 2.2 mmol per L or less than 40 milligram per DL. Acidosis. Clinical feature: a base deficit of greater than 80 MEq per L, or if not available, a plasma bicarbonate level of less than 15 mmol per L, or venous plasma lactate greater than or equals to mmol per L. Severe malarial anemia. Hemoglobin concentration less than or equals to 5 gram per DL, or a hematocrit of less than or equals to 15% in children less than 12 years of age, or less than 7 gram per DL and less than 20% respectively in adults with a parasite count greater than 10,000 micro-L. Hyperparasitemia. Greater than 2% of red blood cells parasitized, or greater than 100,000 parasites per microliter. Renal impairment. Plasma or serum creatinine greater than 265. Plasma serum creatinine greater than 265 micro mol per liter, or 3 milligram per dl, or urea greater than 20 mmol per L. Remember, each of the individual critical feature is important for the diagnosis of severe malaria. An individual patient may have any single complication or any combination of the complications. A patient with one or more of the complications may go on to develop others. Other possible diagnoses in such a patient must be carefully considered. Risk group for severe falciparum malaria. People of all age in areas of low endemicity, like most endemic places in Ethiopia. Residents of areas where there is little or no Plasmodium falciparum who travel to high transmission area. Non-immune pregnant women at risk of some specific complications. Internally displaced person moving from one area of low to an area of high transmission. Children in areas of high endemicity. People returning to highly endemic areas after a few years. Residents in areas with little or no falciparum malaria. Patients who had a splenectomy. Factor known to influence the severity of disease in a malaria infection. 1. Parasite species, immunity, young children, pregnancy, genetic conditions, drug resistance, drug availability, HIV/AIDS, malnutrition. Cause of severe disease. Cause of severe malaria disease. Microvascular obstruction of vital organs. In falciparum malaria, a consistent pathological feature is the sequestration of red blood cells containing maturing parasites. Schizoid, large trophozoite in deep capillaries and venules, affecting organs and tissues including the brain, lung, heart, bone marrow, and gut. Sequestration contributes to microvascular obstruction, to concentrate schizoid in vital tissues, rupture of schizoid. Mechanical obstruction causes hypoxia, altered consciousness, and acidosis. Focal brain damage may use up vital substances such as glucose and oxygen. The parasite also produce waste matter, example lactate or toxin, free iron, toxic oxygen, radicals, and nitrous oxide that are directly injurious to local host tissue. Local host tissues. Why sequestration? Cytoadherence, rosetting, agglutination. Rosetting receptor blood group antigens CO36, CR1, and HS. Endothelial cytoadherence receptor CD31, CD36, CSA. E-selectin, ICAM1, TSP, and VCAM1. Endothelial activation, rolling on endothelium receptor ICAM1 in situ rosetting, vascular occlusion, flow, process contributing to specific complications, altered consciousness, or coma. What are the causes? Processes contributing to severity. Hypoglycemia may be due to impaired production or release of glucose in the liver, encouraged intake in the tissues, increased consumption of glucose by parasites. In children, hypoglycemia complicates other infections. Hypoglycemia in pregnant women. Question. Convulsion. During a convulsion, unconsciousness occurs both during a convulsion, ictal, and for a period of up to several hours after convulsion, post-ictal. Convulsion may be due to the direct effect of parasite in the brain. Metabolic disorders, example, profound anosmia, severe acidosis, or severe hypoglycemia. Raised ICP, raised intracranial pressure. Intracranial pressure, cause unknown and common in adults, does not need specific treatment. Anemia. Anemia is partly due to the destruction of red blood cells that contain parasites. Anemia is worsened due to abnormal bleeding, intravascular hemolysis, renal failure. Non-parasitized red cells are destroyed more quickly than normal during malarial illness. The bone marrow does not function adequately. Acidosis. Relative shortage of oxygen in tissues. This shortage of oxygen is made worse due to hypovolemic shock, severe anemia, salicylates given to lower fever exacerbate this metabolic acidosis. Concomitant sepsis, lack of oxygen, and release of lactic acid. Acute kidney injury, acute tubular necrosis is a common complication in adults, but it is rarely seen in children. It is fully reversible if the patient is kept alive for long enough, usually between a few days to 3 weeks, example, by peritoneal dialysis. Renal failure is most likely to develop due to low blood pressure. Shock. Sequestration is also observed in the kidney. Pulmonary edema and ARDS. Pulmonary edema, non-cardiogenic, may result from excessive fluid replacement by intravenous infusion, especially if there is a renal failure. Adult respiratory distress syndrome, ARDS. Adult respiratory distress syndrome appears to be due to a direct effect of parasites sequestered in the lungs, possibly through release of cytokines. Both of these complications are unusual in children in endemic areas. Clinical and radiological presentation of a woman soon after labor. Differential diagnosis: aspiration, bronchopneumonia, pneumocystis, pneumonia, metabolic acidosis, hemoglobinuria, result from the rapid breakdown of red blood cells or massive intravascular hemolysis in the circulation. Jaundice is more common in adults than in children and is due to hemolysis, liver dysfunction. Shock happens due to jaundice is more common in adults than in children and is due to hemolysis, liver dysfunction. Shock happens due to inadequate cardiac output and poor tissue perfusion, sometimes concurrently with bacteremia. Bleeding disorders causes thrombocytopenia, disseminated intravascular coagulation, hepatic dysfunction, enlarged due to sequestered blood cell and sinusoidal enlargement. Infected erythrocyte fill the sinusoids, causing reduced hepatic circulation and associated splanchnic constriction. Hepatic blood flow is reduced. Hepatic dysfunction is reflected by blood coagulation abnormalities, hypoalbuminemia, hyperbilirubinemia, spleen enlargement. Feature of infection by all four species. Rapid enlargement with or without trauma leads to spleen rupture. Large number of red blood cells present plays a major role in clearance of infections or red blood cells. Differential diagnosis of severe malaria: decrease the level of consciousness, viral encephalitis, bacterial meningoencephalitis, cerebral typhoid, cerebrovascular event or stroke, complicated typhus, relapsing fever, febrile illness with hypoglycemia, sepsis, convulsion in a patient with fever, impaired renal function, acute tubular necrosis due to hypovolemia or hypotension, jaundice associated with fever, viral hepatitis, yellow fever. Treatment objectives: primary aim, prevent disease, mortality treated 15 up to 20%, untreated 100%. These occur within hour of admission. Secondary aim, prevention of recrudescence or treatment failure, transmission or emergence of resistance, and prevention of disabilities. Immediate supportive treatment: ABC of life, correct hypovolemia, correct hypoglycemia, control convulsions, reduce body temperature if greater than 39.5 degrees centigrade, assess anemia and consider transfusion, give antimalarial drug and also consider antibiotics. Observation: possible abnormality, appropriate action. Observation: A. Clinical: breathing, possible abnormality, increased rate or difficulty deep breathing in children. Appropriate action: review urine output and the fluid imbalance, or review urine output and the fluid balance. Assess lung, heart, and the liver size. Chest X-ray if available. If pulmonary edema is demonstrated or seems likely, prop the patient up. Give oxygen IV furosemide 2 to 4 milligram per kg. Treat acidosis with normal saline and bicarbonate. Second, under clinical, body temperature, rectal temperature greater than 40 degrees centigrade, or axillary temperature greater than 39.5 degrees centigrade. Possible abnormality. Appropriate actions: give paracetamol or rectal or oral if not already given within past 4 hours. Tepid sponging and fanning. Aspirin can be given to adults instead of paracetamol, but not to children. If temperature remains high or rise despite 24 hours of antimalarial therapy, reconsider your diagnosis while continuing treatment. 3. Under clinical, blood pressure, possible abnormality, false less than 80 mmg systolic in adult and less than 50 mmHg in infants and children. In children, blood pressure is not always reliable. Check for viral. Appropriate action: review fluid balance, urine output, IV infusion, red and hematocrit. Give plasma or saline infusion if hypovolemia is present. Look for hemorrhage. Take blood for bacteriological culture if facilities are available. Give broad spectrum antibiotics for possible sepsis. 4. Under clinical fluid balance, possible abnormality. Urea less than 17 ml per hour in an adult or less than 0.5 ml per kg per hour in infants and children. Appropriate action: use input and output chart. Weight patient accurately. Catheterize if acute renal failure or pulmonary edema is suspected. Review adequacy of hydration and infusion. Correct deficit of necessary prevent. Correct deficit if necessary. Prevent or manage acute renal failure if suspected. Give fluid challenge: 20 ml per kg of normal saline with furosemide 2 to 3 mg per kg. Dialysis if this fails. Clinical 5 coma score. Possible abnormality: deterioration. Appropriate action: immediately check blood pressure. Reconsider other diagnosis. Provide appropriate nursing care for the unconscious patient. Clinical observation. 6. Conversion. Possible abnormality may be due to malaria, to high fever, abnormal blood glucose level, or electrolyte imbalance. Appropriate actions: check the rectal temperature if greater than 39 degrees centigrade. Manage as above. Check blood glucose and the fluid balance. Check electrolytes if possible, as there is risk of hyponatremia. Correct any imbalance. Give anticonvulsant medicine. Maintain the airway. Treat with IV or rectal diazepam or IM paraldehyde. Observation under clinical: prolonged bleeding from puncture sites of spontaneous bleeding. Possible abnormality: disseminated intravascular coagulation, DIC. Appropriate action: check bleeding time, cross match blood, give whole fresh blood or platelet infusion as needed to correct blood loss and bleeding tendency. B. Laboratory observation. 1. Blood glucose. Blood glucose. Possible abnormality: falls less than 2.2 mmol per L or 40 mg per DL. Appropriate action: review infusion. A child will become hypoglycemic if deprived of glucose for more than 12 to 24 hours. Give IV 50% dextrose or 1 ml per kg diluted with an equal volume of normal saline. Under laboratory observation, packed cell volume or hemoglobin possible abnormality fails less than 50% or less than 5 gram per day. Appropriate action: cross match blood considered. Need for transfusion with whole blood or packed cells or 10 ml per kg. Repeat hemoglobin or hematocrit at regular intervals. Laboratory observation. 3. Parasitemia remains high for 2 to 3. 3. Parasitemia possible abnormality remain high for 2 to 3 days or remain positive for greater than 5 days. Under laboratory, the third one is parasitemia. Possible abnormality remain high for 2 to 3 days or remains positive for greater than 5 days. Commonly remains at the initial level for 12 to 24 hours, even when medicines are fully effective, then falls. Appropriate action: review adequacy of antimalarial medicine and the dosage. Consider alternative or give an additional medicine. Artemisinin derivatives are so effective that exchange transfusion is usually unnecessary. Anti-malarial treatment: IV or IM artesunate, IM artemether or quinine IV infusion. Follow-up: assess for patient recovery. Treatments that are not recommended: corticosteroids, NSAIDs, and NSAIDs agents given for cerebral edema, heparin. Note: waiting for a blood smear result must not be allowed to delay the start of treatment unduly. Occasionally, blood films may be negative, even though the patient is suffering from severe falciparum malaria. A positive blood film does not prove that severe falciparum malaria is the only cause of the severe illness. Pre-referral treatment: first dose of intramuscular artesunate or artemether in non-admitting health center. Rectal artesunate is recommended only at healthy posts for under 6 years children. Rectal artesunate should not be given at health centers as pre-referral treatment unless artesunate or artemether injection is not available. Stocks of rectal artesunate suppositories at health centers should be reserved for healthy posts for use. Errors in the diagnosis of severe malaria: failure to think of malaria in a patient with either typical or atypical illness. Failure to elicit history of exposure, travel history, including travel with a country with variable transmission. Misjudgment of severity: failure to do a thick blood film in a non-immune patient. Failure to identify Plasmodium falciparum in a dual infection with Plasmodium vivax. That means the latter may be more obvious. Missed hypoglycemia: failure to diagnose alternative or associated infections. That means bacterial, viral, etc. Misdiagnosis: making an alternative diagnosis in a patient who is suffering from malaria. Example, influenza, viral encephalitis, hepatitis, scrub typhus, etc. Failure to recognize respiratory distress or metabolic acidosis. Errors in the management of severe malaria. Inadequate nursing care, error of fluid or electrolyte replacement, failure to control the rate of intravenous infusion, delay in starting antimalarial therapy, use of an inappropriate medicine, ineffective antimalarial medicine, unjustified withholding of an antimalarial treatment, dosage of antimalarial medicine or not correctly calculated, inappropriate route of administration, failure to switch patients from parenteral to oral therapy as soon as they can take oral medication, unnecessary continuation of chemotherapy beyond the recommended length of failure to review antimalarial treatment in a patient whose condition is deteriorating, failure to elicit a history of recent intake of medicine, failure to identify or treat metabolic acidosis, unnecessary endotracheal intubation, unduly delayed endotracheal intubation when it is indicated and possible, failure to prevent or control convulsions, failure to recognize minor or subtype convulsions, failure to recognize and treat severe anemia, delay in considering obstetrical intervention in late pregnancy, failure to recognize and manage pulmonary edema, undue delay in starting peritoneal dialysis or hemodialysis, failure to pass a nasogastric tube to prevent aspiration pneumonia, failure to cover with antibiotics if the decision is taken to delay lumbar puncture. Don't forget, identify all severity signs. Pregnancy, high-grade fever, and vomiting are not severity signs by themselves. Treat with IV artesunate only those with severity signs. Artesunate should be weight-based. Artesunate is based on weight. At least 3 doses of artesunate is needed. Periodically test all cases for hypoglycemia and or anticipate and treat all cases for hypoglycemia in case no blood glucose testing. There should be at least one drug to treat convulsion in your facility. Be vigilant of differential diagnosis. Question, comment. Thank you.